process, I'm going to do a tissue pull from the spinous up to the lamina or the LPJ. Anchor my thumb. I'm going to laterally flex, rotate. As I do that, I'm going to step around. I want to make sure that my elbow is close to my upper body. My forearm, my adjusting hand is almost parallel with the floor. Okay, and I have my wrist over-deviated. Okay, and so this is the position that I'm going to be in. Okay, and the thrust is going to again come from the pectoralis muscle, and it's just a quick, gentle thrust. Okay, so that would be for an LPJ contact. So yeah, that's exactly what it is. Yeah. So you guys did this in the second quarter. Why are we doing this? Because that's what we do. Those conditions, those muscles. For a spinous contact, I'm going to do a tissue push from the lamina down to the spinous. So basically, if this is the lamina, this is the spinous. I'm going to bridge. I'm going to feel both of these structures underneath my contact. So I want to be against the lateral aspect of the spinous process. And so why would I use a spinous contact? If I have an open wedge, so if I have a PRS, I'm going to be on the right side, and I'm going to use a spinous contact, as opposed to being on the left side, the posterior lamina, and I'm going to exacerbate the disc. Just a side note, in the cervical spine, when somebody has a disc herniation, right, a disc wedging and that type of thing, particularly the lower cervical spine, where it happens most commonly, they can be very problematic. So you really got to be careful which side that you're on. You can very easily exacerbate a cervical disc, and it could just make that person miserable. Okay, so you really need to be aware of that. So if I have a PRS, okay, SC5 for example, all right, I'm going to get on the lateral aspect of the spinous process. My support hand is exactly the same. We don't change that. Okay? I'm going to push down onto the spinus. I'm going to go from tissue push from the lamina down to the spinus. I'm actually going to be on both of these structures. Okay, again, the pip joint. And then I'm going to do lateral flexion, rotation, and my arm is going to be up, and I'm going to thrust down against the spinous process. Okay. So my line of correction is going to be lateral to medial, okay, against the spinous. Okay, because the orientation of the spinous is actually coming up when I rotate. Okay, I'm going to be thrusting down towards the head piece of the table. Okay. All right. All right, questions with that? Okay, so Atlas, okay, Atlas, the supine work is diversified, all right? So Atlas, we have two adjustments for Atlas, a lateral Atlas and a posterior Atlas, okay? So left posterior to right posterior Atlas, okay? And so for a lateral Atlas, I'm gonna have, again, the pip joint. Support hand is exactly the same, the pip joint. I'm gonna do a tissue push. It's not really a tissue push. I'm not getting tissue out of the way. It's just something that I do to make sure that I'm on the lateral aspect of the TP of the Atlas. So I'm going to slide down the mastoid process onto the TP. I'm going to do lateral flexion, rotation, okay, and the thrust or line of correction for a lateral Atlas is going to be what? Lateral to medial and S to I. Right, so I'm going to thrust down and across the condyles. So for a lateral Atlas, I'm going to slide down the mastoid process onto the Atlas transverse process. I'm going to laterally flex, rotate. My arm is going to be up. Can you see the lateral to medial and S to I in my line of correction? I'm not coming around the table quite as much. And I'm going to thrust down and across the condyles. For a posterior Atlas, I'm going to drop off the mastoid process onto the posterior arch. Okay. My arm is going to be a little bit lower. My line of correction now is going to include P to A. So I'm going to have lateral to medial, P to A, and S to I in my line of correction. So I'm going to slide off the mastoid process. I guess I should do it on this side. Would that be helpful? So I'm going to slide off the base of the occiput onto the posterior arch of Atlas. Okay. Laterally flex, rotate. My arm is going to be a little bit lower. My thrust is actually going to be angled towards the axilla. Okay. Just like that. So contact point with this is the posterior arch. Okay. Posterior arch versus the posterior part of the TP. I can get on the posterior part of the TP, but it's not really easy to get on that structure. Okay. So get on that posterior arch. We know how to find it, and just makes for an easier adjustment. I think the last two are the occiput adjustments. Right. So we have two. We have a thenar contact, and we have a pisiform contact. The thenar contact with contact on the zygomatic arch. Okay. Pisiform contact, I'm going to place a pisiform behind the mastoid process. line of correction is the same, right? And both hands are gonna move in this adjustment too. So the thenar contact, if I have a right superior, you know, an RS occiput, okay? So the right side is superior, left side is inferior. So I'm gonna hook the base of the occiput, okay, on the inferior side with a thenar contact. I'm gonna rotate the patient's head over. I'm gonna place a thenar on the zygomatic arch, just like that. Wrap my fingers around the back of the patient's head. I'm gonna bring my elbows in. I'm gonna lift up on the inferior side, and I'm gonna push down on the superior side. If I wanna use a pisiform contact, I'm gonna put my pisiform behind the mastoid process, and I'm gonna stand facing the table, just like this. And I wanna make sure that my arm is over her shoulder. And I'm going to squeeze my hands together, and I'm going to lift up on the inferior side, and I'm going to pull down on the superior side. So the line of correction and the movement of the patient's head is the same, it's just a different hand position. So. All right. What else do we have in the cervical spine? Seated. Seated. So balance the, I didn't bring a block. All right. We'll have to pretend. Okay, let's grab a chair.